Risk Adjustment, Clinical Documentation Specificity. Today we'll be talking about diabetes mellitus uncomplicated and diabetes mellitus with complications. Tips for success in risk adjustment data validation. Here we have the CMS-HCC risk adjustment model that shows all of the diabetic conditions that risk adjust. There are 748 ICD-10 diagnosis codes that risk adjust for diabetes that are categorized into 3 HCC categories. HCC category 19 that carries a risk weight of 0.105, HCC 18 that carries a risk weight of 0.305, and HCC 17 that carries a risk weight of 0.305. The HCCs are arranged in a hierarchy with HCC 17 being the highest and HCC 19 being the lowest. Only the highest HCC impacts the risk score 1 time per year when completely and accurately documented, coded, and submitted. A disease interaction coefficient also exists for diabetes and congestive heart failure. So when those two diagnoses exist in your patient, there's an automatic coefficient that's added. Here's an example again of the CMS-HCC crosswalk. It gives you the HCC category, which is the variable. In this case, we have HCC 17, 18, and 19. And then it gives you the HCC category description. HCC category 17 is diabetes with acute complications, HCC 18 is diabetes with chronic complications, and HCC 19 is diabetes without a complication. There are numerous ICD-10 diagnosis codes that map into the 3 HCC categories. Each HCC is referred to as a category, and each CC category has corresponding ICD-10 diagnosis codes that map to an HCC based on the methodology from CMS. Here you see the crosswalk for CMS-HCC 17. There's 23 ICD-10 diagnosis codes that map to type 1, type 2, and underlying conditions of diabetes. You see here on the left an ICD-10 diagnosis code, and then you see in the middle the ICD-10 description, and then you see on the right the fact that it maps to those HCC 17s. Here you see the CMS crosswalk for HCC 18. There's 400 ICD-10 diagnosis codes that map to either type 1 diabetes, type 2 diabetes, or diabetes caused by another underlying condition. Again, you see some samples of the diagnosis code here on the left-hand side with the ICD-10 diagnosis description in the middle, and then what HCC it maps to. This is just a little example of all, right? We have type 1 diabetes, we have other specified diabetes, and then we have type 2 diabetes. Just an example of some of the common conditions that map to HCC 18. And here we have the CMS crosswalk for HCC 19. There are 6 ICD-10 diagnosis codes that map to type 1, type 2, and other underlying conditions. Specifically wanting to call out E11-9, which is the most commonly diagnosed diabetes across the nation that goes to type 2 diabetes mellitus without complications. Here's the American Hospital Association official coding guidelines for diabetes mellitus. Diagnosis codes E08 through E89. Chapter 4, Diabetes mellitus. The diabetes mellitus codes are combination codes that include the type of diabetes mellitus, the body system affected, and the complications affecting that body system. Specifically, ICD-10-CM in Chapter 4 has included a separate subchapter and a block of diabetes and diabetes complications specific to E08 through E13 within those categories. So E08 is coding out to diabetes mellitus due to underlying conditions. E09s are coding out to drug or chemical-induced diabetes mellitus. E10s are typically your type 1 diabetes, E11s are your type 2 diabetes, and E13s are other specified diabetes mellitus. Common diabetic complications. 3 diabetic HCCs are defined by presence, type of complication, and numbered by hierarchy. Diabetes with acute complications is HCC 17 for things such as ketoacidosis or hypoglycemia. Diabetes with chronic complications is HCC 18. There are some combination codes in ICD-10 which mostly eliminate the need to code the diabetes and the diabetic complication. So instead of 2 diagnosis codes, the American Hospital Association has introduced these things into 1 combo code. And then there are some other diabetic complications that require reporting of an additional diabetic complication, so you will have 2 diagnosis codes, or it will default to HCC 18 only. Certain conditions do map to multiple conditions or multiple HCCs in diabetes, such as diabetes with peripheral vascular disease, where you'll get HCC 18 and HCC 108, or diabetes with CKD, as long as the documentation meets the requirements for both the diabetes and the complication. Also, document and code as many complications of the diabetes that are present at the time of the visit for accuracy of disease burden. Anything that's not given discrete details in your clinical documentation to code to that highest level of specificity will automatically default to E11.9 when the lacking details are not in the documentation, even when coded with long-term insulin use. So just a few of the actual diabetic complications here on the right. Some diabetes coding changes in ICD-10 about an assumed causal relationship. ICD-10 guidelines identify many diabetic complications where a causal relationship can be assumed for code assignment. These conditions should be coded as related, even in the absence of provider documentation explicitly linking them. So when a causal relationship is assumed, it would be things like your cataract or your CKD or your hyperglycemia, things listed on the right under the subterm with. When a causal relationship cannot be assumed are with diagnoses such as coronary artery disease, hypertension, or hyperlipidemia. This means if you have a condition listed in your progress note that is not related to diabetes mellitus, your documentation should reflect that it is not related. And if your complication is not listed here, your documentation must include linking terms to validate the actual causal relationship. Coders' common diabetes error coding tips. Diabetes with complications example is based on a causal relationship and correct coding guidelines. The situation: diabetes and multiple complications are fully documented within the same progress note. However, diabetes without complications is coded and added to the claim. Recommendation for best practice. ICD-10 guidelines now assume a causal relationship between many common diabetic complications when documented in the same progress note. When assigning an appropriate code for diabetes, pay attention to any complications or manifestations. If the diabetic complications are documented in the progress note, refer to the tabular index to see if a causal relationship is assumed by ICD-10 shown in the previous slide. Is the diagnosis listed under with? Then you'll want to code it as a diabetic complication. Assign the diagnosis code to the highest level of specificity utilizing the diabetes with complication code. If it's unclear, be sure to query for further specificity on the complication or the manifestation if it's not specified, so that you can add both diagnoses if required, or add that one combo diagnosis to include both the diabetes and the complication. Here to the right is an all-inclusive list of the diabetes and those subtermed under with. Any of the conditions under the subterm with, such as gangrene, neuropathy, the full list here to the right, can be coded without the physician stating that these conditions are linked. The classification assumes a cause and effect relationship between the diabetes and certain diseases of the kidneys, nerves, and circulatory system. There are 53 instances of with subterm conditions listed under the main term diabetes. There is a presumed causal relationship between the diabetes and those 53 conditions listed. Otherwise, your clinical documentation must provide the link between the diabetes and the related diagnosis, manifestation, or complication in order to be coded. So continue to use terms in your documentation such as diabetes associated with, diabetes due to, diabetes in, or diabetic such and such. Some diabetes code changes in ICD-10 when documenting the control. Controlled or uncontrolled are not included in the terminology for coding diabetes in ICD-10. Increase in specificity requires for your documentation to include hyper or hypoglycemia for correct code assignment. Out of control, poorly controlled, and inadequately controlled are included in the index and all classify to diabetes with hyperglycemia. If the diabetes is uncontrolled, please include terminology for correct code assignment. Diabetes with a complication or a manifestation. Many times in the clinical documentation, we'll see verbiage such as diabetes with a comorbidity of said condition. A comorbidity is the simultaneous presence of two or more diseases or medical conditions. It's not inferred as related, they're just occurring at the same time. So when it comes to diabetes with a complication or a manifestation, ensure that your documentation is using those terms such as manifestation, which means diabetes involving and or related to an underlying disease caused by or due to, or diabetes with a complication, which would be a secondary disease or condition caused by an already existing one with additional complexity, or maybe a problem that arises because of an illness, such as diabetic neuropathy. Documentation of diabetes with the comorbidity will automatically default to E11.9 Diabetes Unspecified HCC 19. Documentation of diabetes and the diabetic manifestation or complication allows for accurate code assignment and would typically code out to HCC 18. Common diabetes coding and documentation errors. Conflicting documentation in your progress note. At times we'll see with and without complications in the same progress note. It could be system driven, so know your output. We also see conflicting documentation with the type documented versus the type coded on your claim. It could be a less specified version of diabetes documented within the progress note, but a higher specified diabetes is coded on that claim. So remember, the documentation within your progress note must support those diagnosis codes submitted on the claim for that same data service. A lot of times we see omitting of documented diabetic conditions from the claim. So diabetes with complication is documented throughout the encounter. However, coding uncomplicated diabetes in the assessment and on the claim occurs. Or documenting diabetes in an acute visit, but failing to include that diagnosis code in the assessment on the claim for submission. Also, lack of supporting documentation for diabetes. The condition is just simply listed in the assessment without documentation of the MEART, monitoring, evaluating, addressing, or treating, and then use of clinical terms versus documentation of the actual diagnosis. So for example, maybe documentation in the progress note talks about low blood sugar, when indeed it should specify a diagnosis with the status of that diagnosis and the plan for that diagnosis. Detailed clinical documentation allows for diagnosis code accuracy and reporting to CMS. Your documentation should always include the status, the specificity, and the treatment plan for your diabetes. The status of the diabetes, is it stable, is it controlled, or is it uncontrolled? And recall, if it's uncontrolled, to specify, is it hyper or hypoglycemia? The specificity of the diabetic complication. List diabetes, the type, and the complication or manifestation. So don't just list diabetes mellitus type 2 with a circulatory complication, because that leaves the coder asking, what is the circulatory complication? So to get to the full code specificity, in that case, document diabetes type 2 with peripheral vascular disease, and then the current treatment plan for that diabetes. On the right is an accurate statement for stable type 2 diabetes with diabetic peripheral neuropathy, continue scripts for gabapentin and metformin, and that meets the CMS meet criteria. Document and code all diabetic conditions as appropriate when addressed in the encounter, even when those conditions are managed by a specialist. Pulling in documented complications from your specialist notes into your current documentation, specifically your problems list, is best practice to ensure that all chronic conditions are monitored and addressed appropriately as the primary care physician. Documentation solely from lists such as a problems list or past medical history does not meet the CMS meet criteria. Ensure documentation consistency throughout the encounter and the progress note for coding to the highest specificity. Make sure that if it's type 1 diabetes, that it's type 1 diabetes throughout the entire encounter, or if it's type 2 diabetes, that it's type 2 diabetes throughout the entire encounter. So there isn't documentation of type 1 and then somewhere else in the progress note type 2. And then ensure that your complications are listed, or your manifestations are listed, or if it's uncontrolled, then specify what is uncontrolled. And then know your progress note output. Again, there are certain things within progress note templates from an informatics perspective that may be bringing information into your progress note that you're not aware of. So be sure to go ahead and look at your progress note output. Diabetes mellitus, default coding versus specified coding. When your clinical documentation is lacking high-level details to get to the necessary code assignment, your diabetes will always default to E11.9, diabetes uncomplicated, unspecified, type 2, and controlled, HCC 19, risk weight 0.105. The specificity needed in your documentation to gain better code assignment would be, is it type 1 or type 2? Is it controlled or uncontrolled? And is there a complication or a manifestation? So clinically think about two diagnoses both needing to meet the CMS meet criteria, the diabetes and the complication. Clinical documentation at the highest specificity allows for accurate diagnosis coding and risk score assignment. So looking at this example here, kind of what's missing. Clinical documentation lacking specificity, again, is going to default to HCC category 19, diabetes continue metformin, or diabetes reviewed blood sugar log. In both of those cases, the default code is E11.9, which is saying that it's diabetes type 2, unspecified, uncomplicated, and controlled. Try rather clinical documentation to the highest specificity, which codes out to HCC category 17 and 18. And the example would be diabetes mellitus type 2 with peripheral neuropathy, blood sugars controlled, currently no numbness, follow-up in 6 weeks. Or another example would be type 2 diabetic polyneuropathy, continue metformin and gabapentin as prescribed. So specific to diabetes, we've discussed the 3 HCC categories, HCC 17, 18, and 19. Recall it's the high-level clinical details in your clinical documentation that allow for diagnosis code assignment to the highest level of specificity. Specific to diabetes mellitus, recall that we need to know the type of diabetes, the status of the diabetes, and if there is a diabetic complication or manifestation, we need to know what the diagnosis is of that complication and manifestation. Some common diabetic conditions are kidney, circulatory, neurological, ophthalmic, and skin complications. Be sure to specify what the diabetic condition is. ICD-10 code rules allow for combo coding and then additional code also rules. So if the diabetes is complicated, be sure to specify what is the complication. The documentation criteria must be met on both the diabetes and the complication, so think 2 separate diagnoses. There are combo codes that include the diabetes and the complication in one code, and then there's code also rules that ask for the associated condition to be a separate code, so it'd be 2 separate diagnoses. The example goes as follows. Type 2 diabetes mellitus with diabetic peripheral neuropathy is a combo code. You would use E1144 and get HCC 18. But type 2 diabetes mellitus with CKD stage 3 has a code also rule. So E1122 would be a code for your diabetes with a kidney complication, and then you would need a code also rule to specify what the kidney complication is. And in this case, it's CKD stage 3A. So the diagnosis code for that would be N18.31, which would bring an additional HCC 138. Here's an example of a diabetes mellitus decision tree that's been completed to show you how we get to code accurate specificity. So again, ICD-10 diagnosis codes through E08 through E13 go to HCC category 17, 18, and 19. So documenting to the highest specificity allows for coding to the highest specificity. In this case, the decision tree says, is it type 1 or type 2? And we've selected type 2. Is the diabetes controlled or uncontrolled? And we've selected controlled. Is it uncomplicated or is there a complication? And we've selected that there's a complication. If there's a complication, what is the diagnosis of that complication? In this case, it's peripheral neuropathy. And therefore, you can see we get to diabetes mellitus type 2 controlled with peripheral neuropathy, ICD-10 diagnosis E1144, HCC 18. Diabetes and some common diabetic complications. Neuropathy, renal manifestations such as CKD and nephropathy, retinopathy, circulatory conditions involving the peripheral arteries, osteomyelitis, and gangrene. You'll see here on the right, when we talk about a kidney complication, try to get specific. Is it nephropathy or is it CKD? If we're talking about ophthalmic complications, is it retinopathy or macular edema? If there's a neurological complication, is it neuropathy, circulatory complications, peripheral vascular disease, skin complications, diabetic ulcers, and other complications such as hypoglycemia or hyperglycemia? Be sure to specify what the chronic diabetic complication is and include specificity in your documentation such as right, left, or bilateral, a diagnosis for the complication or the manifestation, and a direct connection if needed. Here's a sample of a generic encounter form with the 4 acceptable areas highlighted in the progress note that are acceptable for risk adjustment data validation code extraction. Recall the CMS criteria: meet, monitor, evaluate, address, treat. Be sure to document the diagnosis in one of 4 places and what you're doing to monitor, evaluate, address, and treat that diagnosis, as well as put that same diagnosis in the assessment for a 1-to-1 match. CMS-HCC risk adjustment coding impact example. Here's a scenario where we use a 72-year-old female with a base risk score of 0.323 across all 3 scenarios. The scenario on the left shows the impact of all HCC conditions coded appropriately and submitted on a claim to the highest level of specificity. The scenario in the middle shows some HCC conditions coded and submitted on a claim to a lower level of specificity. And then the scenario on the right shows no HCC conditions coded or submitted on a claim. Ensuring all diagnoses are documented to the highest level of specificity in your progress note and appropriately assigning and submitting those diagnoses on a claim is detrimental to success in risk adjustment. A quick recap regarding risk adjustment data validation. What is a risk adjustment data validation audit? The HCC diagnosis code submitted on your claims for payment must be supported in the clinical documentation in your progress note per the risk adjustment data validation guidelines. When an ICD-10 diagnosis code is assigned in your claim, the clinical documentation in your progress note for that same data service must support that diagnosis code being submitted to the highest level of specificity. Recall, it's that standalone progress note that must support the diagnosis code submitted on your claim for payment. It's not the medical record in its entirety. Don't forget to document the actual diagnosis, the status of that diagnosis, and the plan of care for that diagnosis, as well as listing the same diagnosis in your assessment and then putting that diagnosis code on your claim for best practice success and risk adjustment. We really appreciate your time today. Thank you for all you do, and remember, the small changes made now to include high-level details in your documentation will make a huge difference in the future. Thank you.